Hello, welcome to the short where we're talking about a medication called Labetalol. Labetalol is going to be used for hypertensive emergencies as well as preclamptic and eclamptic patients. It's classified as a non-selective beta blocker and an alpha adrenergic blocker as well. Mechanism of action. How are we going to get a reduction in blood pressure? How is this working? So this is going to reduce cardiac output. So it is going to do this by reducing the heart's ability to contract forcefully and reducing the heart rate. Those two things together are going to reduce the cardiac output. It's also going to reduce systemic vascular resistance. So it's going to vasodilate to a degree or cause less vasoconstriction. So reducing the systemic vascular resistance and the cardiac output will reduce the blood pressure. Some byproducts of this medication, though, or potential side effects, are going to be, talked about, reduction in heart rate, reduction in blood pressure, dizziness, drowsiness, fatigue, weakness, headache, vertigo, and bronchospasms. Just a note here, again, this is a non-selective beta blocker, so some collateral effects are going to be potentially bronchospasms, which is a good segue into our contraindications, and we'll lead off with asthma patients, patients experiencing COPD, and emphysema. These are patients who do not need encouragement getting bronchospasms, all right? Other contraindications are going to be sensitivity to labetalol or beta blockers, AV blocks, so your patient's experiencing a first degree, second degree, type 1 or 2, or a third degree heart block, severe bradycardia, and cardiogenic shock patients. We did mention that this will be used for hypertensive emergencies and preclamptic or eclamptic patients. Before diving into the regimen of using it, this is going to be a medication that requires online med control, okay? So if you start to experience a patient with a hypertensive emergency or a patient potentially experiencing preeclampsia or eclampsia, I want you to consider this regimen and contact med control with that plan, all right? That plan being, okay, we have a systolic pressure above 220 and or a diastolic pressure above 160 combined with signs of organ damage, specifically stroke, acute coronary syndrome, aortic dissection, congestive heart failure / pulmonary edema. So those things combined together. Basically what we're saying is we're not just treating high blood pressure, we're treating a patient whose high blood pressure seems to be negatively impacting them acutely right here, right now. So we need to reduce that. We are going to give 10 milligrams IV push. If hypertension persists, specifically a systolic above 220 and or a diastolic above 120, you can repeat that 10 milligram IV push to a total of 20. Talking preeclampsia or eclamptic patients, 10 milligrams IV push, repeat if systolic is above 160 and or diastolic is above 110. So a total of, again, 20. The regimen is the same, although the parameters are a little bit different. In the hypertensive emergency, the systolic and diastolic pressures are kind of bumped up, versus the preeclamptic and eclamptic. Systolic is 160 and diastolic is 110. As well as the parameters around preeclampsia and eclampsia, those are covered in another short, and if you want clarity on those, direct you to that video. So that is Labetalol. If you guys have any questions about it, please speak out, and thank you for your time.